Good afternoon and welcome to this fifth webinar in our series on healthy ageing. We've had a fantastic sign up to this event from a very diverse range of specialisms and backgrounds. So welcome all, and I think people are still joining as I speak. So please sit back and enjoy. For those of you who don't know me, I'm Alison Giles. I'm Associate Director for Healthy Ageing at the Centre for Ageing Better. I'm a joint appointment with Public Health England, where I sit in the older adults policy team. We're joined today by three great speakers: Millie Brown, who's Evidence Officer here at the Centre for Ageing Better; Safia Iqbal, who is Healthy Housing Manager at Derby City Council; and Shelley Emerson, who's Prevention and Development Manager in the Humberside Fire and Rescue Service. We will also have our Housing Senior Programme Manager, Henry Smith, on the chat this afternoon. So he may well be posing questions out to you, the audience, about what the Centre for Ageing Better can do in this space to support joined up working on housing and health and make sure that people can access the support that they need to make improvements to their homes. But also he may well be able to answer questions where our panel may not know the answers, because Henry is the font of all housing and health knowledge. So just some housekeeping before we start. We're live streaming this session on Ageing Better's YouTube channel, and the webinar will be available to view on demand through that channel immediately after we've finished. So do share the link with other colleagues. And we will also be sharing all the slides after the event. All live attendees are in listen-only mode. So if you have questions for the panel, please do post them using the Q&A box, which you'll find in the control ribbon at the top or the bottom of your Zoom screen. You're also welcome to use the chat box for any comments or responses that you have. And please just make sure that in the TO box, it says all panelists and attendees so that everyone sees your posts. I think it might default to panelists only, but it would be great if you can broadcast your comments and suggestions to everybody who's on the webinar today. And please do also use the chat function to introduce yourselves to each other and to share your own projects and links to work, because part of the purpose of this webinar series is to connect the audience to each other and to share good practice, and also so that we at Centre for Ageing Better and Public Health England can learn about all the great stuff that's going on out there. And for those of you who are tuning in on YouTube, you're welcome to join in the conversation on Twitter using the hashtag AgingBetterEvents. My colleagues are going to curate any questions that come through on Twitter using that hashtag, and they'll feed them to me to pose to our panel. So do feel that you can join in the discussion this afternoon. By way of background, today's webinar is one in a series of webinars that we're running in collaboration with Public Health England to explore the principles of our Healthy Ageing Consensus Statement. And I think a link is being posted in the chat now for those of you who are not familiar with the consensus statement. The statement sets out the 5 principles or areas for action that we think taken together will promote healthy ageing. And the theme of today's webinar, as I hope you've all realised, is housing and health, which is one of the principles of the statement. Please do look at our website or at our YouTube channel for recordings of our previous webinars in the series, which have covered tackling ageism, the importance of community connections and participation, tackling poverty, and putting prevention first. So as I say, this is the 5th one in the series, and this is a focus on housing. Poor housing can contribute to and exacerbate many long-term health conditions, and we want to improve the quality of our existing mainstream housing stock, and particularly focused on those homes in the private rental market. What we know is that we have a growing proportion of older private renters, and we want to improve the conditions in the poorest quality private rented accommodation and identify ways of supporting low-income owner-occupiers and renters to access funds to repair and improve their homes. And we hope that our 3 speakers today will be able to give us their insights into how we can achieve that ambition. So our first speaker today is Millie Brown. Millie is Evidence Officer at the Centre for Ageing Better, and she's going to set the scene in terms of what we know about the relationship between housing and health. So over to you, Millie.
Thank you, Alison. So I'm here today. I'm an Evidence Officer Centre for Ageing Better to talk to you about our catalogue of work looking at homes and health. So next slide, please. Let's start. So for you that don't know, Centre for Ageing Better, our vision is a society where everybody enjoys a good later life. So therefore, we aim to create change in policy and practice informed by evidence. We're a charitable foundation funded by the National Lottery Community Fund, and we're part of the What Works Centre network. But mainly our cohort is to look at 50 to 70-year-olds, but actually today we'll talk about housing and health affects all ages. So next slide, please. So the work I'm here to talk to you today is a part of our Good Home inquiry. This was launched in July 2020 and will run until mid-2021. The purpose of this is to establish why so many of England's homes are in poor condition, as well as exploring what we need in a good home. So at its core, and it's an evidence-based analysis of England's housing policies to determine the causes of and solutions to the poor quality of much of our housing. So as the key thing here today is homes and health, which is one of the 4 themes a Good Home inquiry is going to focus on, I'm going to briefly outline the relationship between these two, but also referencing to the initial reports to come out of the inquiry, which are Homes, Health and COVID-19, which we commissioned the King's Fund to carry out, and also Getting Our Homes in Order, Why England's Homes Are Failing Us, which we commissioned Ipsos Mori to carry out for us. And the main thing is the inquiry supports the Centre for Ageing Better's goal of reducing the number of homes as non-decent by at least 1 million by 2030. Okay, so next slide, please. So what is the current housing landscape? There's actually 4.1 million homes in England currently that do not meet basic standards set by government. And shockingly, more than 2 million people aged 55 occupy those homes. So that's just under half people that occupy these homes that endanger their health and their well-being. The most common issues are excessive damp, inability to heat homes properly, and poor design, which relates to inaccessibility, and then disrepair. And I'm sure we're all aware that the COVID-19 pandemic has exposed and amplified housing-related health inequalities even more than ever before. Social distancing measures have meant that we have people spending more time at home that are hazardous, unsafe, and also actually a lack of security of tenure. This is why the discussion of homes and the effect of our health is even more important than ever, and we really need to stop thinking of the two as separate, and neither should services related to housing and health continue to be separate. And just to point out that it's not about, while work at Ageing Better is about how it affects the individual, actually it's very costly, and it's £513 million estimated to spend by the NHS on first year treatment costs for over 55s living in these poor quality homes, but it actually reaches up to 1.4 billion for the whole population. Next slide, please. So as I said today, I'm going to take you for a very quick spin through our current work on homes and health. And the first one of that is Homes, Health and COVID-19 by the King's Fund. This report reviewed existing literature on the association between housing and health. Unsurprisingly, the conclusions were that poor quality housing has a profound impact on health. The conditions of home, insecure tender, and also the wider neighbourhood characteristics all have a considerable effect on health and well-being. Some of the main key themes that came out of this that were, in particular, living in a cold and damp home has significant impact on health and can worsen the impact of many common long-term health conditions, and those conditions that particularly are experienced by older people. So these are things such as arthritis, respiratory conditions, as well as the increase of the risk of stroke or a heart attack. Further to the actually living with these conditions, shockingly, 1 in 5 excess deaths during winter attributed to cold housing. And that therefore means that 1 in 5 excess deaths are unavoidable if we address the issue of cold homes. So following on to cold homes, alongside the dangers of this, the report again highlighted that the main cause of accidental injury-related deaths amongst older people is falls in the home. Many of which could easily be prevented by simple repairs and adaptations. So therefore, and also actually some additional research Centre for Ageing Better did during the COVID-19 lockdown found that over 31% of people reported decline in physical and mental health due to their home during lockdown. So these stats that we already have are ever exemplified by the current situ, and the way things are going, we're all going to be at home for quite a while as well. So next slide, please. So following on from this, the second output from our Good Home Inquiry is called Getting Our Homes in Order, Sorting England's Homes Out by Ipsos Mori. So the point of this was we had already collected the data through the King's Fund to show in quantitative mainly how our homes affect our health. However, at the Centre for Ageing Better, we really value lived experience within our research, and we really value lived experience within our policy. So therefore, we commissioned a longitudinal piece of research looking at people's experiences of living in poor quality homes. It was a diverse sample, however, the age range was to 50 to 70, and all participants had a shared experience of living in a poor quality home. And I think one of the main takeaways from this is actually, because a longitudinal piece of research, when we started this research, all of the participants did not realise the effect that their poor quality homes were having on their health. And for me, this is a really big thing we need to address, because if we want to adopt a preventative approach to these kind of to homes and health, we need to actually incite a behaviour change, and part of that is educating the effect of health homes have on our health. So in terms of the actual research that came out of it, the two strongest issues, again, unsurprisingly, were keeping the home warm and dry and moving around the home safely. So again, the majority of participants described how cold their homes were, and I think it's key to mention this was across all housing tenures. Whilst that they are prevalent in more, owner occupiers and PRS both have an enormous amount of homes that are as poor quality. So actually, again, linking to my earlier point, participants talked less about the health risks of damp and mold, but actually they talked about the feelings of shame and embarrassment, which is obviously quite a big toll on mental health as well. There was also a preference for short-term fixes over long-term solutions, which again endangers safety because they weren't carried out properly or done by reliable tradespeople, for example. So and again, this persistent feeling of helplessness was across all tenures. For homeowners, pay for works, whereas renters felt unable to rely on their landlords. So I think we need to keep remembering, well, you know, we're talking about the effects of physical health, it does have a big toll on mental health. So secondly, again, I said moving around the home. So for example, those with mobility issues were most vocal about their concerns and moving around the home safely. However, all participants expressed significant stress and anxiety to a fear of injury in the home. And they also, again, talk about not seriously thinking about when they bought their 3-story house with 3 sets of stairs, how that would affect them in the future. And again, this comes back to the preventative approach and making people put the dots together between their homes and health before, unfortunately, it becomes too late. And they may not either want to move or not actually have the opportunity to move, which is, for a lot of people, that is the case. So, and I think also, for example, one thing before I finish, and I wanted to highlight that one social renter's bathroom actually was so inaccessible at this point, and she had fallen many times in there, caused her injury, that she was now washing in her kitchen sink or travelling to her family's home to shower. As you can imagine, this was severely affecting her mental health, and some poignant words before I finish was, I deserve the right to wash free like anybody else. When you have to wash in the kitchen or rely on family members, why should I have to do that? So I think it's really important for all of us to think not about physical health is so important, but also the mental health. So just one more slide, if you go to the next slide, please. So I think the whole thing here today is talking about actually improvements to our homes can be both beneficial to individuals and highly cost effective. The current situation is not inevitable. Some low cost adaptations to the homes can result in a 26% reduction in falls, so over a quarter. For me, that's a big number. And also £1 spent on home improvement services to reduce falls is estimated to lead to savings of £7.50 to the health and care sector. So it's not just about helping people, but also we can see the cost benefit and also pushing policy in that way. So yeah, final slide, please. Thank you for listening to me today. I know that's been a very quick run through because there's a lot of, I imagine, in these reports. So I would really encourage you to go to the Ageing Better website and read them for yourself, because there's some really great stuff which kind of will push along this agenda for us. Okay, thank you.
Thanks, Millie. That's brilliant. Really comprehensive run through of the evidence and the work that Centre for Ageing Better is doing. Please do post questions to our panelists in the chat, in the Q&A as you go along, and do put comments in the chat. We're going to move to our next speaker, Safia Iqbal. So as I mentioned, she's the Healthy Housing Manager at Derby City Council. And Safia is going to describe the excellent partnership work that's going on across Derby to identify and support those whose housing is putting them at risk of poor health. So I think what Safia will cover will directly speak to some of those issues that Millie has raised. So over to you, Safia.
Hi, everyone. I'm Safia. I run the Derby City Council Healthy Housing Hub. So today I just want to briefly go through what the aim of the Healthy Housing Hub is. So we try to solve the ever-increasing problem of hospital admissions, along with improving quality of life for the people we help by making their homes healthier. So I'll go through, who we are, why we do what we do, and how we do what we do. Next slide, please. Right. So the Healthy Housing Hub, so we provide help to some of Derby's most vulnerable residents living in unsafe and unhealthy conditions, where our work helps prevent, delay, or lessen the seriousness of a poor health outcome. So our intervention can help, significantly reduce costs to the NHS and social care. The hub is part of Derby City Council's Better Care Fund plan and has been crucial in supporting Derby City's joint strategic needs assessment in identifying and suitably dealing with poor housing conditions, as well as housing-related health inequalities, and identifying them as key challenges within the council's health and wellbeing strategy. The hub it's built on successful partnership working across a broad range of organisations and services, including health and care professionals such as GPs, community matrons, OTs, social workers, police and the fire service, and various community groups. This increases the likelihood that the hub's interventions are instrumental in preventing, reducing, delaying or lessening the occurrence or severity of an undesirable health occurrence, and helps to access vulnerable individuals who might otherwise miss out on or fail to engage with the council or with health or community services. Next slide, please. So why do we have the Healthy Housing Hub? The Building Research Establishment estimates that the cost to the NHS alone of poor housing is 1.4 billion per year. Now, through the Healthy Housing Hub, we try to maintain mental and physical health of vulnerable residents through improving homes. As we know, safe and suitable housing can reduce home accidents, falls, and general health risks. And this leads to a reduction in avoidable hospital admissions. So hence, reducing spend to the NHS. Right. Next slide, please. Right. So we work with vulnerable people whose home living conditions are impacting or have a potential to impact detrimentally on their health. And they are referred to us by health and our various partners who've identified their patient or client as being in priority health need and living in unsuitable or unsafe housing conditions. And as you can see from that photo, the picture, the kind of hazards that we come face to face on a daily basis. So that picture shows, cold home, fire risk, damp, etc. Next slide, please. So that's other forms of hazards that we come across, trips and fall risks. Next slide, please. And some more, we come across hoarding, fire risks, poor hygiene, and these all have a huge impact on our customers' health. Next slide, please. So the way we do our processes, so an officer from the team will visit a property where a hazard or a risk has been identified. So, for example, if it is a cold home, for example, either boiler's broken down or they have no heating, for example, we will obtain quotes from for the work that's needed from contractors that we've procured, and the work will be completed and assessed to make sure that it has been done to the standard required. Sometimes we do come across clients who can self-fund the works, but there's that trust issue where they don't have the know-how to appoint their own contractors. So we step in and we can facilitate those works. But we also award healthy housing assistance if they're on a means tested benefit. And then it does depend on the works. For example, cold related works, we'll obviously need a professional contractor. But for minor adaptations, for example, things like handrails or grab rails, these can be done through our handy person service. So some examples of work that the preventative work that we carry out, as I've said, repairing boilers, gas fires, at times installing full central heating systems, removing trip hazards, making electrical installation safe, and also helping with fuel poverty. Next slide, please. So last year we completed nearly 1,800 referrals, of which 833 were more complex cases. These were clients referred to the hub primarily by health, care and community-based colleagues due to higher risk and multiple vulnerabilities. 888 handy person service interventions were delivered to help vulnerable people to remain living independently at home in greater safety and to facilitate hospital discharge. 78 child home safety improvements were made for vulnerable newborn and preschool children. And a further analysis of those 833 complex cases revealed over 2,000 intervention outcomes. The top interventions being falls prevention works, heating improvements, income maximisation and personalised advice. Over 2,400 health conditions were revealed. The top 4 being cardio, diabetes, poor mobility and respiratory conditions. Over 900 hazards in the home were identified. The top hazards were falls risks, cold, damp, fire, electrical risk, hoarding and personal hygiene, and 410 onward referrals were made into other services. So making that principle of, making every contact count. Next slide, please. So our work, as I said, it helps delay or lessen the seriousness of a poor health outcome. Our intervention can help reduce costs to the NHS and social care. But more specifically, our intervention can help reduce home accidents, falls and general health risks, reduce demand on health, social care and emergency services, maintain independent living within own home, facilitate hospital discharge and reduce readmissions, make the home environment suitable for care services delivered in the home, increase client and carer well-being, and enhance childhood development, where poor living conditions may impact on health or educational attainment. Next slide, please. An evaluation of the service was carried out by our Derby City's Directorate of Public Health using an NHS number data tracking tool to monitor health service usage before and after the hub intervention. And the results show that at 1 year post-intervention, fewer hub clients were in need of health and care services. Next slide, please. I just want to show you some, share some feedback that we've had from our service users and our professionals. Let you read that for a sec. Next slide, please. We were named the Home Improvement Agency of the Year at the National Healthy Housing Awards in 2019. Next slide, please. Now, I'm very proud of what we do. I believe that we deliver a fantastic service, but we face many challenges to enable us to continue. So we need a confirmed ongoing funding stream to best invest to save. Our biggest challenge is yet to come, as we're funded by Better Care Fund. The year-on-year allocations make it difficult to develop and expand the hub to its full potential. And with the uncertainty of the Better Care Fund also results in the uncertainty of the hub. Now, where we live and the quality of our homes has an important impact on our health and how we feel. While we hear much in the news about the shortage of housing, we have heard less about the quality of our existing homes and how the very fabric of our housing affects our well-being, risk of disease, and demand on health and care services. We need warm, safe, and secure homes to help us to lead healthy, independent lives and to recover from illness. Also, closer working with health professionals will help most efficiently identify patients at greatest risk of housing-related health impacts. And also, we need to involve housing very early in the medical assessment and hospital discharge. This will raise potential risks within the house earlier with the hub, and we'll be able to respond quicker and reduce the time spent by people in hospitals whilst waiting to be discharged. Thank you so much for listening, and if you want any further info on the hub, please contact us. Next slide, please. Okay, thank you very much.
Thank you, Safria. That was really, really brilliant. I think I should have issued a health warning before you started, because some of those photos were truly shocking. But as you said before we started, a picture speaks 1,000 words, and I think we have to keep reminding ourselves of the condition that some people's homes really are in. And I think going back to Millie's point about not everyone recognizing that it has a health impact, and that people find that they cannot afford to make those changes. And I think something's just gone in the chat about people, there's potential that people feel quite overwhelmed with the condition of their home, and where would they start. So really, really thought-provoking. Thank you. I'm delighted now to introduce our final speaker, Shelley Emerson. Shelley is Prevention and Development Manager in the Humberside Fire and Rescue Service, and she's going to describe the crucial role that the fire and rescue services can play in identifying housing issues and identifying people at risk and ensuring that they get the support that they need to make adaptations. So over to you, Shelley.
Thank you, Alison. Good afternoon, everybody, and thanks for inviting us along to share what we do at Humberside Fire and Rescue Service. So we sort of teamed up with the with NHS Hull and the CCG a few years ago now to pilot a scheme called the Hull's First team. So FIRST is the Falls Intervention Response Safety Team. It was identified that through health there was a high number of falls across the city of Hull, and we looked to see if we could sort of collaborate together and try and alleviate some of the pressures that were put onto the local health services. So it was after the pilot scheme was really successful. Initially, it was set up with 8 firefighters. We've moved along since then, and we've seemed to have gone from strength to strength. So we are funded through the CHCP, so the City Healthcare Partnership. Funded through the CCG, and delivered through the City Healthcare Partnership. So Hull First was a rapid response team to prevent any complications caused by patients with the long-term life. So looking at preventing ulceration, to relieve that pressure on health from patients who if they'd been potentially laid on the floor for several hours. Our response time is the maximum an hour. But generally, I think it's on the next slide actually, but we're there within probably around 15 minutes. So we get, rapid response to those people who have fallen in their own homes. So in addition to the picking up patients The team obviously also provide a range of medical observations. So that's assisting in indicating levels that are increase the risk to falls. And then they will refer that on to the CHCP for a falls assessment after our team have been. Next slide, please. So the delivery, so the teams attend around 90 falls per month. And I think when it was initially set up, we were almost, I don't like to say target because you like to think people are falling, but we were sort of looking around 50. So you can see that it's still a high number of people that are falling who obviously need our assistance. So the type of patients we go to are non-injury, and they're all registered with a Hull GP. So the average response time is for 25 minutes. Excuse me, there, I thought it was 15. 25 minutes, but that agreed maximum is 60 minutes that we will get somebody to that person who's fallen. So there's certain different referral routes that will come through, things like Lifeline, it will come through the CHCP directly, and they will contact our control room, who will then mobilise our falls team. So due to the success, we've actually merged now 2 teams. So we've got now 4 firefighters with 7 of the public safety advocates who are the not operational firefighters. They're out there carrying out what we term as a safe and well visit. And for any agencies out there that do work with fire and rescue services, this is a national project that we run through the NFCC, so the National Fire Chiefs Council, where we'll go into people's properties and we offer fire safety advice. We will install smoke detection if it's required, but obviously test what they've already got in the property. If it's looking a bit shabby, which generally we find quite a few are, we will obviously replace it at the time of the visit. So we paired the 2 teams up because we saw a real benefit to actually, if we've got somebody who's falling in the home, our public safety advocates have had additional training where they can signpost to other agencies, so we can, as Safia said previously, making every contact count while we're in that property. So the safe and well approach sort of derived from the fire safety check, but we look at far more in depth. So we have those very brief conversations with that person while we're there to look at any possible other signposting that may be required. So we look at sort of housing, Lifeline, generally on Lifeline, but Lifeline, See and Solve, or if there's any safeguarding issues, we can refer on. The good thing with that is, we find is that upstream prevention can stop future falls, which again is going to alleviate those pressures on the NHS and local health services. But also it's about, keeping that person sort of living healthier for in their own home for longer. It reduces hospital admissions and obviously reduces the amount of ambulance attendance as well. So it's a bit of a win-win situation, really. And we obviously get to deliver our fire safety advice about, making those small behaviour changes to encourage that, so that they don't become a victim of fire as well. So the firefighters obviously have real in-depth training from the advocates. So they are now able, if they're almost like upskilled the firefighters to, so almost firefighters with that additional knowledge to make those identify and make those referral opportunities. Next slide, please. So the safe and well visit has adopted the make every contact count approach. So when attending a patient, they carry out a safe and well visit if it's appropriate at the time. So some of the agencies that we do refer to is within Hull, but these are agencies that we'll refer to across our service area when we're just carrying out safe and well visits generally. But these obviously go to as well for people who have fallen in the home. So we have the warm zone, or like in the East Riding, there's health through warmth, the smoking cessation. So obviously that's a really big one for us because still, 95% of fires are caused by careless discarding of cigarettes. We look at falls assessments. We encourage we tend to visit people over 55, so we encourage them to have the flu jab while we're there. Social isolation, so we may refer to Age UK, carer support services. Again, see and solve if it looks like that person's maybe struggling with their housekeeping, or their hygiene, things like that, looking for that additional support. Sometimes people just don't know where to turn. So obviously we can make those initial signposting calls for them. We do use the Make Every Contact Count website to, obviously, if people are able to self-refer or to self-serve with the information on there. We make referrals to the MASH, which is the Multi-Agency Safeguarding Hub, which also includes hoarding. Just on the hoarding, we did some work, Steph actually, who was going to be speaking today, with the local authorities, and established a hoarding protocol. So how we all work together to, as different agencies, to alleviate some of the issues around hoarding, because that was becoming quite an issue for us, certainly in our service area. So we have a hoarding protocol now, which is very much like a VARM, but specifically around hoarding. Next slide, please. So our public safety advocate, obviously they've had extensive training. So the training we receive for Safe and Well, which is all approved by our partners, is around social isolation, smoking cessation, cardiovascular disease, falls prevention, and cold homes. They're our sort of priority subjects that we train our advocates in, but they also have awareness around dementia, oxygen therapy, emollient creams, crime prevention, and health and well-being. So we cover a wide range of subjects that we can signpost individuals to, and it's that early upstream prevention. So hopefully in years to come that will relieve a lot of pressure on the health service. So we have a targeted approach, which is driven by data and intelligence from previous incidents. So the type of individuals that we will target are people who are living alone, over the age of 50, generally smokers, and these are all from incidents that we've attended in the past. So the more people have of these, that would indicate to us there's more risk factors within that property. Restricted mobility, the living rented accommodation, they may be alcohol dependent, and the attendance time for our fire and rescue service. So if they live in a very rural location, again, that would increase their risk if they was involved in a fire. So they're our target group. However, we do people can refer themselves to us, or agencies can refer to us as well, which will be coming up shortly. So they receive the standard Safe and Well visits as the patients that have fallen, and obviously we receive quality referrals from other agencies. So we also offer training to all our partner agencies that we work closely with, so they know the signs to look out for that makes somebody at risk from fire. Next slide, please. So one of the City of Culture, actually it was, we looked at some of the key features or issues that we had in our Hull area. So we chose Hull because Hull was the City of Culture. So we chose, and some of the engines at all our Hull stations were wrapped to raise awareness on local health, I could say inequalities, but local health risks. So we had prostate cancer, health and well-being, the white ribbon, which is for domestic abuse, and organ donation. And the organ donation actually was really interesting because there was I can't remember the exact figures, but their sign up for organ donation almost doubled within the Hull area when we launched the fire engine, which was really interesting to see, what a difference just that, almost that publicity had made. Next slide, please. So obviously, if people want to make a referral to us, you can visit our website, there's obviously the link there, which I presume we can probably put into the chat if people want to, obviously, if you're not local, I would contact your local fire and rescue service or look on their website, because they will be offering something very similar to what we do at Humberside. Some of the topics may change because it tends to be driven by local demand. Obviously, we have our 0300 number where you can speak to somebody in our public safety centre who will also give you over the phone advice. Thank you.
Wow, thank you, Shelley. That's really, really fantastic. I love the success that you had with the organ donation wagon, because it just goes to show the power of the fire and rescue service as a vehicle, pardon the pun, to get messages out there, because it's such a well-regarded service that fantastic use of a local resource. Can I invite all the panelists, all the speakers to come on to video so that we can see you, and we'll go into a little bit of a sort of Q&A. We've had one question come through actually from my colleague at Centre for Ageing Better, Louise, saying really impressive work in Derby, and I think she wrote the question before we heard from Humberside, so we'll extend that to Humberside. Is there national guidance or support that would help all areas roll out a similar service? We'll come on to funding in a moment, but what do you think would help from a national perspective, either coming down from the NHS maybe or through MHCLG, that would help roll out the sort of work that you're doing, but to other parts of the country? If I could ask Safia first and then Shelley.
Yeah, I mean, we've had the Healthy Housing Hub now for nearly 7 years. And each year we have had to rely on funding. So yes, I think at a higher level, may it be health colleagues or the government. Yeah, we do need something to highlight the problem of older private housing stock, because at the moment I feel there's a lot more focus on new builds. And we seem to forget the older housing, and the older housing is occupied by the most vulnerable in society, and I feel we do seem to forget that. So I do feel, yes, we do need something, but I attend a lot of conferences, I go to a lot of seminars and things, and there's a lot of research that's already been done, but I do feel we just seem to be banging our heads against a brick wall, and we're not, no one really seems to be listening. But as I've said, we've been doing this now for 7 years, and it's heartbreaking sometimes when you walk into a property and you actually see how the occupants are living. I mean, heating, that's a basic necessity, but there are so many that don't have that resource. We go into properties where it isn't just the over 60s or over 50s. We deal with young families, and there are young families who don't have heating. For example, they probably have it downstairs, but there's no source of heating upstairs. We've supported young families with young children where we have had to install heating upstairs, for example. And you can imagine kids with asthma, eczema, how that gets exacerbated with the cold conditions in the home, and how that actually affects, their school, for example. And through our evaluation, we've shown that just doing minor adaptations in a home, it makes a huge difference. So yes, I do, feel that something higher level does need to be done, but at the moment there just doesn't seem to be anything. But there's a lot of evidence and research to support that there's a huge need. And also, we rely on funding. It's a discretionary service that we provide.
Yeah, well, we'll come on to. I'd like to come back to the funding, funding issue. Shelley, from your perspective, do you think there is something that nationally could be rolled out to support the partnership working?
I think the Hull has been a real success, and I think sort of having it almost with sort of fire the CCG and CHCP, it can become quite a lengthy process, and I think sometimes either people give up or, you know, and I think it's just appreciating it's not going to happen overnight. And I think it's just, I mean, I was in Hull sort of managing the Falls team 3 years ago, and some of the things we were discussing then around the Falls team actually going into sort of residential care homes, looking to almost give the care staff advice on how to prevent falls within the care setting, and we're still not there yet. So it does take time, but I think there's a real appetite there. I know certainly in the East Riding, it's something that's been muted several times, but it's just never sort of got over the line. And I think, I don't know whether it's people change. I mean, in the fire service, people change posts nearly every week. So I don't know whether it's just because we don't have that continuation of, you know, whether people moving about, just things drop off, or we are all, and I know the last year has been extremely challenging, hasn't it, for services, that things just drop off the shelf if it's almost looking for those quick wins. But I think because it's like with fire service, we obviously have the union and the fire service union, so everything has to almost like go through them as well if we're involving operational staff. So it does become quite complex, but I think if people are willing to, you know, really stick at it, then, you know, the funding is a big thing. But actually, when you look at, you know, the money it can actually save in the long term, you know, I think certainly from when we first started just going out, you know, maybe 15 years ago, fitting a smoke detector in people's homes to where we are now. And I think we've reduced fires in the homes by about 80%. But imagine if we could do that with some of the health, you know, the demand on health, we could reduce that by 80% in the next 10 years. That would be enormous, wouldn't it? That's saving. So I think sometimes we can't look for those quick wins. We've got to see it to the end and really stick at it, really.
Yeah, I mean, I think Millie, you know, the work that we're doing at the centre, there's no shortage of evidence of the need or of evidence of the impact that it could have, and, you know, on the health service and on quality of life. So do you think that the Good Home Inquiry will achieve something that hasn't been done to date, and sort of maybe unstick some of this at a national level? How optimistic are you?
Yeah, like you said, there is now a lot of evidence pointing to that. I think the housing inquiry is a lot wider than what I've spoken about today. It's not just about the research element of that, are the research outputs, but actually the part of it is also looking at good practice throughout the country. So from hearing from Shelley, for example, today, I know I've been writing notes while sitting here listening, and that's kind of what from now on we're looking to. And I know we have a lot of members here from the Ageing Better Inquiry staff as well, because now we're looking at how can we talk about funding streams, and we're especially looking to drag in our localities partners at the moment to look at locally how can we bring that funding down, how we can also protect that funding as well.
Yeah, great. So on funding, it is going to be the elephant in the room, I think. So Shelley, you're CCG funded, is that right?
Yes, that's correct. And obviously we lose CCGs, don't we, very shortly. I don't know if it's next, I think it's the end of mid this year, I think. Oh, it's maybe they've maybe already gone, maybe tomorrow.
It might be tomorrow. And we moved to ICSs, and I think for Safia, you're the Better Care Fund. So
that's right.
In both cases, it strikes me that the funding is quite vulnerable, and that you probably have to keep remaking the case every year, do you, for keeping the service going?
Absolutely, yes.
Yeah, I think ours is, I think we review it every 3 years, I think, if my memory serves me correctly, but I think it's every 3 years.
Yeah, I think with us, we have to each year argue with our social care, you know, directors, because it's how you prioritise. So, you know, there's a lot of, you know, need for social care as well. So we're sort of, you know, begging every year, really.
Yeah, which is crazy, because this is a really strong preventive approach, isn't it? Absolutely. So do you think the new NHS structures and the sort of ways of working kind of much more using data better to identify patients who might be at risk. Do you think that's going to help with these sorts of services? Do you think you'll be called upon more and recognised more if GP practices are systematically looking at their patient lists and thinking this person keeps coming in with chronic lung disease, you know, I wonder if there's a problem with their housing? Is that going to help, do you think? Yes,
absolutely. At the moment, in Derby, we have GP care coordinators. So like you've just said, if someone does, you know, is a regular visit to the surgery with a chronic, you know, condition, and then we do get alerted, and, you know, the care coordinator makes a referral to the hub, and then because of whatever concerns, then we will go out and do that visit. It's the same with, we work closely with EMAS. So each time a patient is admitted in hospital, you know, we're already aware of that referral, and EMAS have identified the hazards and the risks in that property.
Is that the ambulance service? Sorry,
that's
East Midlands?
Sorry, East Midlands Ambulance Service, that's right. So we will make contact with the hospital. We also have a hospital to home team, social workers based in the hospital. So they will also identify patients after, you know, they've done their assessment. But for some reason, patients do fall through the net. Mm. And then when we're told they've already been discharged, but no one's actually carried out that assessment, that home assessment. Yeah. So I always say, when they're having an assessment done at hospital, they just need some basic questions on, you know, on the form, and say, you know, what is your home condition like? You know, yeah. Is your boiler work? Something very simple and basic, and that should be an alert. You know, and we have a secure referral system, and we do work closely with our hospital teams, you know, with the discharge wards, you know, and they do referrals to us. But still, a lot more can be done, though.
Yeah. Thank you. Shelley, I don't know if you want to come in on that, because I'm actually going to bring a member of the audience in to speak to us. But I just want to ask if you wanted to add anything there.
No, it's there was something, but it slipped my mind. If I remember it again, Alistair, I'll mention it.
Brilliant. Okay, so we have Emma in the audience, who is from an organisation called Lendology, and I think it'd be just interesting if Emma wouldn't mind unmuting and just telling us a little bit about it, because one of our concerns is for some people won't meet the threshold for accessing funds, you know, public sector funds. So just want to hear a little bit about a scheme that's supporting people to borrow money. Hi, Emma. So please do just, you're on mute. Thank you.
Better, is it? Good afternoon.
Yeah, that's great.
Alison, thanks very much for inviting me to just sort of join in a bit, really. I work in a CIC, so we're a community interest company based in the southwest, and we work lending council funds in order to support people to make essential home repairs. And it's been really fascinating listening to both Shelley and Sophia, because we come across people just like you are, Sophia, down here in the West Country, who are living in one room with no heating, still no boilers. And we have a lot of properties that just simply aren't fit for living in. And again, Shelley, we're working with a fire service to help refer and cross-refer, because we see the value of that. We really come across a major stigma with some of our clients who really, as we've said, don't want anybody to know that they're living in these sorts of conditions, and they feel ashamed of it. And it's one of the real challenges that we find. And one of the ways that we've found it's been really positive, one of the sort of positives that we could take from the pandemic has been that we've dealt with a number of clients online who probably wouldn't have got in touch with us, because historically the council said we had to do home visits. People didn't want people seeing that there was a loan company there. So we lend at an affordable rate, and we lend at a set rate for each of our clients, and we only lend what's affordable. So we try and help those people live a better quality of life, either by preventing a slip, a trip, or a hazard piece, or whether it's a simple replacement of a boiler, or if it's something monumental like the roof that's caved in. And this happens, and people are just sat there going, they have nowhere to turn. So we're funded by our local council partners, so we charge them a tiny subscription fee, and we also run on the funds that we make from the income generated from the loans that we have out. And it's such a marvellous way of supporting homeowners, and yet it's such a shame that it's not run across the whole of the UK, to my mind, because it works. We've been running for 17 years now, recycling the funds. So we've lent 16 million, we've had 9 million repaid, and we're on track to lend another 2 million this year. And I'm delighted to have been given an opportunity to go, please, we need to be talking about this in more detail with more councils, because it works.
That's great. Thank you, Emma. And please do put in the chat if there is a link to your website, or if you want to sort of explain what you think the model is that other councils could adopt. That would be very helpful. Thank you. There is a bit of chat going on from Rico from the I've lost it now, the National Building Federation, I think, is it? National Federation of Master Builders. Sorry, Rico, I don't know if you're there and if you wanted to come in at all, because you've been asking a few questions, but also sort of wanted to speak. But if not, then please, or if you want to, please unmute. But otherwise, we've just got a couple of minutes left, and so we've sort of talked about funding. I wonder how have the services been getting on during the pandemic? Have you been able to continue as usual, or do you think that there's now going to be a bit of a backlog? Safia or Shelley, whichever you want to answer.
We've prioritised. So we sort of, as I say, we have our visits. So we have A, B, and C visits. So A would obviously be where there's immediate threat to life. So because obviously we get threats of arson and things like that on people's properties. So those we will still carry out as because of the severity of the risk. If we've got people where it's come from sort of a partner that there's maybe concerns around sort of safeguarding issues or anything like that, and they think we need to be in there. So we've still managed to do those. The B risk and C, what we tend to do is we do a telephone engagement first, and then we obviously do a dynamic risk assessment from that. And then if we feel that there's a need to visit the property, we obviously go through some risk assessment questions. For example, have they been tested for coronavirus in the last week? Have they been, have they been in contact with anybody? And have they got any symptoms? So we'll do a triage before we actually go into somebody's property. Once we're in there, we maintain the 2 meters of social distancing, and we have full PPE on when we go in. But we've still been managing to do those. The only visits we haven't been able to do are ones where people have requested us themselves, unless again they've come out really high risk. But they tend to be more partner referrals from police or domestic abuse partnerships.
Okay, and Safia, any comment from Derby's perspective about the pandemic and how it's impacted your service?
Yeah, so during the first lockdown, we didn't do any visits. Similar to Shelley, we did have a traffic light system, but majority of our clients didn't want to be visited. They were either shielding or they just didn't want to take the risk. But in Derby, we established a community hub. So we got involved with delivering food parcels, collecting people's medication. So we sort of diversified. We still supported our residents. And then during the second lockdown, we started to do a telephone risk assessment. So then we did start to do home visits, but obviously taking all the correct precautions.
Yeah, and thank you.
Yeah.
Great. Sorry, Rico, I could see you're on camera, but we're sort of out of time. But thank you so much for contributing to the chat. And I think we'll get back in touch with you afterwards. I think we've run out of time, but thank you so much to our speakers and to our audience for such a sort of lively and interesting discussion. It's clearly sort of something that we need to keep promoting and thinking about. So a virtual hand clap of thanks to our speakers. A link to our feedback form has been posted in the chat box. So please, can you just spare us a moment to give us some feedback on the webinar? It's an evaluation form, that would be great. Our next webinar in this series is on Thursday, the 29th of April. I think we're posting a link now to that, when we will be exploring a different aspect of homes and neighbourhoods, which is looking at active travel and how active travel could be a route to enabling more older adults to increase their physical activities. So thank you again, everybody, and we look forward to seeing you next time.